All right, welcome everyone. Our first briefing of 2026 session. As we know, we're here to talk about federal action and its really dreadful harm on jeopardizing food stability for Marylanders, SNAP benefits, Medicaid. Exacerbating the situation is Congress has allowed the Affordable Care Act the subsidies to expire. So all of this is sort of coming together at a time where Marylanders most need it. And so we thought we'd have this hearing to hear about, not just hear on the news or anecdotally, but really get our hands around and our arms around what the impacts really are. So we're excited for the hearing today. But before we get into that, we are super excited to have our new speaker with us. And I want to welcome you, Madam Speaker, to Appropriations. Give you the floor.
My first visit this session, first committee that I chose to visit. And I want to thank you for your work. I know you're going to work really hard, particularly this session, and your staff. I certainly appreciate you. I don't take it for granted. So over the last decade, Maryland cuts its uninsured rate in half from 12% in 2013 to 6% where it is today. So there are many people in all 24 jurisdictions that for the first time, have insurance, and that is important. And that's directly attributable to the expansion of the Affordable Care Act that it gave hundreds of families coverage through Medicaid. And it was thanks to the work of the Maryland Health Benefit Exchange. Michelle Everly, who I love and have so much respect from working on the Health and Government Operations Committee, I want to thank you. Now Congress and the President have decided to play politics with the health care of 320,000 of our most vulnerable neighbors, people who make less than $22,000 for a family of one and less than $45,000 for a family of four, plus refugees and asylees. Those are the very poor. Tell me how many of you can actually live on $22,000 if you're one person, or a family of four, $45,000 after you pay rent, your mortgage, your food, and everything else you need. We couldn't do it. I know I couldn't do it. So last month, Congress allowed the ACA premium tax credits to expire, driving up premiums for our neighbors who buy insurance on the Maryland Health Benefit marketplace. Last session, the General Assembly, with your support of you and the committee members, anticipated this inaction by the federal government by authorizing a state-based subsidy as a backup. So we did that in Maryland, and I believe we're probably the only state in the nation, if I'm not mistaken, that has done that. So over the past 2 years, the General Assembly and this committee have ensured that 600,000 Maryland kids, and thank you so much again to the Appropriations Committee, participated in the Sunbox, which is a program, as you know, that provides a lifeline to families in the summertime. And these are kids that in the summer wouldn't have a meal if we did not provide it, because they usually get their meal at school during the school year. Now Congress and the President are undermining that progress, adding significant burdens to the SNAP recipients and the state by demanding more paperwork, which is really a barrier of hardworking senior citizens and working parents. And this committee right here will have to find a way in the next several years to budget for hundreds of $millions in additional state funding for SNAP, because the federal government is now placing that responsibility on us. And I believe that it's going to be over $600 million. So I know your work is cut out for you. I do not want to be in our place, but we are. But I do want to thank you for your dedication in your work.
And thank you, Madam Speaker, again for being with us. I think your presence here says everything about your commitment and this House's commitment to health care and providing benefits for Marylanders. And that's no surprise, because you've spent 20 years on HGO building one of the best, robust health care delivery systems in the country. And we can't let this president derail that in 1 year. So we're going to do everything we can. Thanks for being with us.
Thank you very much. I really am. I sleep better knowing that, Mr. Chairman, that you and your committee are doing this work. You have the experience, you have the grit and determination to make this right. And we're really blessed to live in Maryland.
Absolutely.
Thank
Amen.
you.
Speaking of the committee, I want to just acknowledge our subcommittee chair who has worked on these issues with you and with us. And any opening comment, Subcommittee Chair Shetty?
Thank you, Mr. Chair. Thank you, Madam Speaker, for those excellent remarks. I think it really sets the stage for the incredible challenge that lies ahead of us for this state. While this challenge was created at the federal level, I know that all of us here know that it impacts every single corner of our state, every district. You do not have to have a D or an R on your jersey, as one of my good friends here in the General Assembly likes to say, to know that that this is like a hungry kid is a hungry kid in Prince George's County and Montgomery County and Baltimore City, Garrett County, Eastern Shore. These are challenges that every single corner, every district in this room and across our General Assembly will be facing. So I just want to thank you, Mr. Chairman, for prioritizing putting this briefing first for our committee. I think it will be one of the greatest challenges that we have in this session to sort out. So thank you, and thank you, Madam Speaker, for your wonderful remarks.
Thank you, Subcommittee Chair Shetty, and thanks for your leadership. So let's get to work on it. We're going to start with a presentation from Department of Legislative Services. We have Tanya Zimmerman, our Operating Budget Manager, as well as Ann Braun, Operating Budget Manager. Please welcome and your team.
Thank you. We're going to present an overview of the impact of the One Big Beautiful Bill Act and the end of the expansion of the enhanced subsidies under the health insurance marketplace. We'll start with the SNAP impacts. Particularly starting with the, go ahead, the next slide. The impact on the changes to the cost share requirements. So before OBA, the federal government paid 100% of the federal benefit, or 100% of the benefits for SNAP, and the administrative costs were evenly shared between the state and the federal government. Beginning in federal fiscal 2028, states will be responsible for cost share if the payment error rate is 6% or higher. The cost share increases along when the payment error rate increases, with a maximum of 15% cost share when the payment error rate is 10% or higher. In general, the state's cost share will be determined based on the payment error rate in the third preceding year. So for example, for federal fiscal 2029, it would be based on 2026. That does provide some certainty because those numbers are released before the budget planning process begins for the next year. So we will know this summer what we will need to plan for fiscal 28. The Act does authorize delayed implementation for states with a payment error rate when it's multiplied by 1.5. If it equals or exceeds 20%, it's a 1-year delay to 2029. If the federal fiscal 2025 rate meets the criteria, into 2030 if the federal fiscal 2026 rate does. The next slide shows the payment error rate since 2017. Payment error rates were not issued during 2020 and 2021 because of COVID-related flexibilities. As you can see in this chart, in all years, Maryland would be responsible for cost share if the criteria had been applied then. The highest payment error rates have occurred since COVID. Some of that had to do with the timing of when the COVID-19 flexibilities ended and the recertifications. This was also impacted by the change in eligibility and determination systems. The department has brought the error rate down to 13.64% in federal fiscal 2024, which is the most recent information available. At that level, Maryland would qualify for a delay, but really any decrease from that level, Maryland would not qualify for a delay. DLS estimated that the impact for the state cost share in state fiscal 2028 the total benefit cost would be $1.28 billion. That accounts for some of the other benefit and eligibility changes. So it would be about $64 million at that level for each 5%. The impact in state fiscal 2028 would be about $144 million. An annualized cost of that would be about $200 million. In the first year, it's only in effect for 3/4 of the year. The next slide looks at the administrative cost sharing. So this increases more immediately. This increases from 50% to 75% beginning in federal fiscal 2027. So part of the budget that you'll be considering this session. Based on the fiscal 26 appropriation, the annualized impact of that would be about $80 million, though it actually would depend on how much was claimed per year. Turning to the next slide, this begins to look at the changes in the impacts on recipients. So this first slide discusses the work requirements that were in effect prior to OBA. So able-bodied adults without dependents were limited to 3 months of benefits in a 36-month period unless working or participating in employment and training for an average of 20 or more hours per week. There were exemptions for people who are physically or mentally unfit to work, pregnant, caring for a child, or other reasons for exemptions. And this state does receive discretionary exemptions that allow for kind of an individual delay for 1 month per exemption per individual. These requirements, as I mentioned, were in effect already for certain recipients. And so between May 2024 and July 2025, which was the most recent data available from the department, there were about 30,000 cases that were closed, at least temporarily, due to the failure to meet work requirements, of which about 8,000 reopened during that period. The next slide looks at the changes under OBA. So it increases the upper age limit for who is considered an ABOD from 54 to 64. It also expands the requirements to include some parents, so it's parents who have children, only have children that are between 14 and above. As of October 2025, which was the most recent data reported by the department at the time of the presentation, the department reported about 666,000 SNAP recipients. Based on May caseloads, DHS reported that there were about 80,000 adults that would be newly subject to the work requirement. The total number of recipients was roughly similar between the 2 months. A portion of these people are likely to qualify for exemptions or be complying with the work requirements. DHS began screening new applicants and recipients who had redeterminations due beginning in November 2025. It will be a phased-in impact for current recipients, so it depends on when their redeterminations would otherwise occur. Because individuals can receive benefits for 3 months without loss of benefit for meeting the requirement. And USDA indicated that November will not count because of the government shutdown and the impact on benefits. March 2026 is the first month we would expect to see impacts on recipients for potential losses due to failure to meet the requirements. Turning to the next slide, this also talks about a few other changes related to the work requirements. It did remove certain exemptions that had been provided under the Fiscal Responsibility Act related to people who are homeless, veterans, or former foster youth. Turning to the next slide, this looks at some other eligibility changes. This provision excludes certain lawfully present individuals from receiving benefits. This primarily affects refugees, asylees, and certain other humanitarian parolees. Initial USDA guidance indicated that these individuals would be permanently ineligible even after a change in status. Updated guidance returns to prior law so that after a change in status, they would be eligible for benefits. Turning to the next slide, this looks at some impact on the benefit amounts households would receive. So prior to OBA, households were able to exclude income that exclude in the calculation of what is income energy assistance benefits that were received. In addition, as part of the calculation of benefits, you're allowed to deduct certain housing-related costs if they exceed certain levels. That includes utility costs. And particularly, you could receive that deduction, or were more likely to receive that deduction if you received a low-income home energy assistance program in Maryland, known as the Maryland Energy Assistance Program, benefit of $20 or more, and that allowed individuals' cases to get higher benefit levels than they might otherwise qualify for, or without documentation, I should say. New law changes it so that it applies only to disabled or elderly individuals. This also began to be implemented in November for new applicants and existing applicants who have redeterminations due. There isn't sufficient data available at the moment to determine what the impact on benefits will be, but it is expected to be a substantial impact for those who lose the deduction as a result. These people could still qualify for this deduction based on documented utility costs, but that would require additional documentation to be provided. And the final slide I have on SNAP is just a breakdown by jurisdiction of the May caseload of that 80,000 individuals compared to the May caseload. And with that, I'll turn it over to Ann Braun to discuss the Medicaid changes.
Thank you, Madam Speaker and Mr. Chairman. So to discuss some of the OBA provisions affecting Medicaid. The first is that the bill establishes work requirements for adults served under the ACA expansion. The requirement is for 80 hours per month of eligible work or educational activities. Certain groups would be exempt, like medically frail adults and parents with dependent children of certain ages. And I believe the Department of Health's presentation should speak more to implementation details, like what is known so far on how those exemptions would be applied. But just wanted to point out that there are some exemptions for those new work requirements under Medicaid. These requirements are set to begin at the start of 2027, but the effective date could be extended if the HHS secretary approves that states made a good faith effort to comply. The next provision I'll cover is the frequency of eligibility redeterminations for ACA expansion adults would increase from once per year to every 6 months beginning in 2027. The Department of Health estimated that there are administrative costs to increasing redetermination that would be over $20 million. The next provision I'll cover relates to Medicaid's coverage of immigrant populations. Both provisions take effect this October. The first changes the definition of qualified immigrants to remove refugees and asylum seekers. That is expected to affect 15,000 individuals who may lose their Medicaid coverage. The second provision would make it so that the enhanced federal match for emergency medical services for undocumented immigrants who would be in that ACA expansion group would be reduced to the standard 50% federal match. MDH wasn't claiming that enhanced match for this group, so this second provision doesn't actually have any impact in Maryland. So this next section discusses what those three provisions are expected to cause in terms of disenrollments. There's an expected disenrollment of 130,000 Marylanders in the ACA adult expansion group to be disenrolled from Medicaid. That's about 40% of the most recent counts of ACA expansion adults. The annual impact on Medicaid's budget from those disenrollments are projected to be about $1.4 billion in total funds, and that includes $140 million in general funds that would be reduced due to those disenrollments. Due to the later implementation dates of those provisions, most of the impact would be seen starting in fiscal 2028. And as I had mentioned before, there are administrative costs to making these changes, including IT, staffing, and communications or outreach, and that would partially offset the reduced Medicaid spending. This next slide shows how the projected disenrollments would be distributed by local jurisdiction, and that's based on each county's share of recent ACA expansion enrollment. This next section relates to provider tax provisions. The first slide just shows what the current assessments are. Maryland collects assessments on hospitals, nursing homes, and managed care organizations. In fiscal 2026, hospital assessments provide a combined total of $738 million, and nursing home assessments provide $158 million, which would also receive federal matching funds in addition to those figures. And so the OBA provision would reduce the current 6% cap of revenues on the hospital assessments. It would reduce by 0.5% each year until the cap reaches 3.5%. This provision's not expected to affect Maryland in a material way, as the current hospital assessments are already near the 3.5% cap. Moving on to other projected impacts of provider tax changes. And so although the cap isn't expected to make a huge impact on the budget, there are two concerns related to the implementation of those hospital assessments. The first is that Maryland collects the assessments through the HSCRC's Hospital Rate Setting Authority, rather than CMS approving those provider rates. And so this creates some uncertainty moving forward, as it's not clear how the OBA policies would be applied. The second is that HSCRC's rate setting authority is only for some excludes some hospitals from the assessment. And so to meet the federal requirement for uniform and broad-based provider tax requirements, it's possible that those exempted hospitals would newly have the assessment applied to them. And the next provision focuses on cost-sharing policies. And so here I'll just highlight that some fees are eliminated in October 2028, but states would be required to have some form of cost-sharing. It would be up to $35 per service for certain ACA expansion adults. Maryland Medicaid currently has copays on prescription drugs, but depending on how OBA is implemented, any additional cost-sharing requirements that might be enforced could create a barrier for healthcare access. Another change prohibits federal reimbursement for all services provided by Planned Parenthood for 1 year from the enactment of OBA, and so that goes through July 4th of this year. MDH estimated that $2 million in state funds would be needed to replace the federal funding. And there have been legal challenges to this provision that led to temporary injunctions in September and December of 2025, but I believe the provision is in place now. Just to highlight a few other changes, this slide shows that OBA reduces the timing for retroactive coverage that's provided when individuals first apply to Medicaid, and then it gradually reduces certain MCO rate enhancements as other provisions. And then this last section talks about the Rural Health Transformation Program that was established in OBA. This provides funding of $50 billion across all states over 5 years. 50% of that funding is allocated to states evenly. And I just wanted to note that eligible rural providers are broader than just hospitals. They include federally qualified health centers and mental health centers. And so the next slide notes that CMS announced recently an award of $168.2 million for Maryland in the first year of this program, and that Maryland's plan for funding, or for using that funding, includes initiatives for healthcare workforce, promoting access and innovative care, and nutrition initiatives. So that will conclude the Medicaid provisions. I'll pass it back for health insurance marketplace provisions.
So I'll be covering changes to the health insurance marketplace. First, with some background on premium tax credits. A premium tax credit is a refundable credit that assists eligible individuals and families with the cost of premiums for health insurance that's purchased through the health insurance marketplace. An advanced premium tax credit reflects the application of the premium tax credit to a monthly insurance payment. There are certain eligibility requirements for receiving a tax credit, including income limits and citizenship status. Regarding a special enrollment period, currently Maryland offers a continuous special enrollment period for individuals under certain income levels. OBA prohibits households entering the market through this special enrollment period from receiving an advanced premium tax credit or cost-sharing reductions. This doesn't affect households entering the marketplace due to a qualifying event. On the next page, I'll discuss pre-enrollment verification and auto renewals. Currently, new enrollees receive conditional eligibility while going through the verification process, and there are also auto renewals for enrollees who take no action during open enrollment. OBA requires certain information to be verified before receiving coverage, which effectively prevents auto renewals. This impacts a lot of enrollees, with nearly half of marketplace enrollees auto renewed in calendar 2025. Regarding immigration status, U.S. citizens and lawfully present immigrants are currently eligible to enroll in marketplace coverage and receive advanced premium tax credits or cost-sharing reductions. Maryland was also approved for a waiver that would allow immigrants of all immigration statuses to enroll on the exchange. However, MHB delayed the implementation of these new eligibility requirements until 2028 due to workload capacity constraints. OBA limits coverage to lawful permanent residents and certain other populations, and lawfully present individuals also lose eligibility for premium tax credits. Regarding enhanced premium tax credits, tax credits were first implemented by the American Rescue Plan Act of 2021 and further extended by the Inflation Reduction Act of 2022. These enhanced tax credits expired after calendar 2025, but there are ongoing legislative efforts in Congress to potentially extend them in some form. The end of the enhanced tax credits are expected to have an impact on enrollment and affordability, with about 190,000 enrollees losing some or all financial assistance for insurance. On the next slide, this shows market premium increases. The end of the enhanced tax credits contributed to an increase in market premiums, with an average increase of 13% in calendar 2026. This is compared to an increase of 6% in the prior year. This graph shows sample monthly premiums and how in each metal plan the premiums increase in 2026. To address concerns about the impact of the end of enhanced premiums on affordability overall, legislation was introduced last year to authorize a state-based subsidy program. On the next slide, this shows the parameters of the state-based subsidy program. The state-based subsidy program is intended to reduce the cost of premiums by providing subsidies to partially replace the loss of these enhanced tax credits. The parameters for the program were approved in August 2025, and the program was implemented on January 1st of this year. Parameters include fully replacing enhanced tax credits up to 200% of the federal poverty level and phasing down replacement levels from there. The next slide has information on program cost. Regarding program costs for fiscal 2026, a budget amendment added $52.3 million to cover subsidies through the program for the first half of plan year 2026. This corresponds to the second half of fiscal 2026. The next slide discusses the funding source for the program. The state-based subsidy program is supported by a 1% state provider fee assessment. This is the same funding source as the state reinsurance program. The graph shows the closing balance of that state provider fee assessment in blue, showing that the balance is expected to decrease significantly in fiscal 2026. And the last thing I'll discuss are enrollment trends. The uninsured population is anticipated to increase with the end of the enhanced tax credits, but the state-based subsidy program is intended to mitigate some of those enrollment losses by making plans more affordable. As of January 11th, MHB reported a 2% increase in enrollments through the open enrollment period compared to the prior year, although new enrollments declined by 20%. And now I'll pass it over back to Tanya.
Yeah, so these last two slides look at the DLS estimate on the impact on the state from these SNAP and Medicaid provisions. This was the estimate produced for the Spending Affordability Committee forecast. So overall, it's expected to increase state spending beginning in 2026 related to administrative costs to implement the Medicaid eligibility changes. Medicaid administrative costs are expected to be higher in all years as a result, but the biggest impacts are on 2026 and 2027. The Medicaid overall costs would go down because of the eligibility changes. SNAP costs increase beginning, are estimated to increase beginning in 2027 with the change in the administrative cost share, though increase in 2028 when the cost sharing would be implemented. The net impact on the state, DLS estimated was about $100 million per year, a little higher kind of in the out years. All of that would depend on the actual impacts on enrollees. The final slide looks at, just provides an overall estimate about the impact on enrollees that DLS estimated to produce those estimates. With that, that concludes our presentation. We're happy to take any questions.
Well, thank you so much for the excellent presentation, as always. Are there questions for the Department of Legislative Services? Delegate Christ.
Thank you. So for that rural funding, is behavioral health also included in that potentially? Do you know?
I believe that is an eligible use. So far, I think it's still being developed exactly how the funding will be used, and maybe the health department could provide more detail. So far, I think those three large initiatives has been the focus so far.
We'll ask them the same question, if there's any way that we can ensure, if it's still being developed, if we can hopefully influence that decision to include behavioral health, that'd be great. Thank you.
Thank you, Mr. Chair. Would you just remind us what exactly the payment error rate is for SNAP, or not what the amount is, but what it means? What's the definition of that?
So the department can speak to the exact definition, but there are two components to it, which are the calculated overpayments and then underpayments. So it captures both overpayments and underpayments based on the actual information. So the department could provide probably the specific definition, but it does capture both over and underpayments.
Thank you, Mr. Chair. Thank you for this excellent presentation. I missed you guys over the interim, except for the, so thank you. I'm looking at slide 13 with the estimated number of individuals newly subject to work requirements. And this began in May 2025, or these are numbers that are from May?
It was the numbers that DHS estimated based on the May caseload.
Got it.
It did not actually begin to be applied until November, and it would, as people are determined, the redeterminations come up, they would be screened for whether they meet the requirements to be considered.
Okay, got it. And remind me the calendar for how quickly these redeterminations are done?
I believe the department said it would be about a full year before we would see the full impacts. They can speak if there are kind of specific flows to it, though.
Okay, thank you. And then I see here, I mean, it's an excellent county by county breakdown, right? Because, and jurisdiction breakdown. So you see this really does impact individuals from across the state. And the categories of individuals were veterans, unhoused individuals, and what was the third?
Former foster youth,
yeah.
or the groups that lost the exemptions that were provided under the Fiscal Responsibility Act. These numbers would also include the changes in the age requirements as well as expansion to some parents.
The changes to age requirements, you mean to seniors?
Seniors and, yeah.
To seniors who now have to go to work in order to get the eligibility criteria met. and unhoused individuals, veterans, And so, I see, for example, not to pick on any particular jurisdiction, but I'm just going to pull Frederick out of the hat, 2,119 individuals newly subject. And so what happens if these individuals are not able to find work, 20 hours of work or training?
So there is the opportunity to meet the requirements through training as well. The state does receive some discretionary exemptions that can assist for 1 month per exemption. But ultimately, if you are unable to meet the requirements, you would lose benefits after 3 months for not meeting them.
And some of these individuals may have natural barriers to employment, right? It's harder for people who are unhoused to get employed. It is harder for a child who is aged out of the foster care system in some instances to get employed steadily. It is harder for an older person who maybe they were laid off in their older years. It's harder for them to get employed. And so these parameters that exempted them from work requirements had a policy reason before. And now without these individuals having the benefit of it, we will see a significant disenrollment, I think, in these populations. And then I wanted to ask you, thank you, that's very helpful. And then just kind of similarly around your ACA disenrollments by county, there seems to be quite a bit of a range, right, depending on who's doing the estimating here. But on page 19 of your slide deck, can you talk a little bit about what this could mean? So I know our speaker gave a really great presentation or remarks at the beginning of like the impact of lowering our uninsured rate in our state, right? And how that has impacted ability to access care. And what happens to individuals across the state and hospital systems in these counties that are disproportionately impacted by ACA and Medicaid disenrollments? Well, what could happen to the ER wait times, for example, and access to care? Because these individuals without access to insurance will likely go to the emergency room for basic care, correct?
Yes, this is showing on that slide who would be disenrolled from the AC expansion group. It was about 40% of that group with the most recent enrollment count, and they'd be disenrolled from Medicaid. And I think the policy is also if they're not eligible through the work requirement, I think they also are ineligible for the AC tax subsidies and other policies. So yeah, they'd be disenrolled from Medicaid.
Okay, and this would have a substantial impact given that all of us are very focused on affordability, and families in particular. This would have a deep impact on individuals' pocketbooks, right? And the families' pocketbooks and the ability to afford healthcare, food, necessities, and the energy program benefits as well, or would be impacted, correct? For some of those folks. Okay, thank you. Thank you, Mr. Chair.
Chairman, and thank you so much for the work that you all have done on this presentation. I had a question about slide 27. You talk about the Rural Health Transformation Program, and I was Googling what is the definition of rural, and for different federal agencies, they have different definitions. So I wanted to ask if you knew what definition they were working from before dispersing the $168 million.
That is a great question. I'm sorry, I don't know off the top of my head how it was defined for this program, but that's something I'll look into. If the health department has an answer, that question might be better geared towards them, but if not, I will get that answer for you on how that applies with this program.
Thank you, Mr. Chair. Thank you all for your presentation. I know that we are all concerned about the substantial impacts that OBA is going to have on our state and our individuals. I was looking at the specific group for the unhoused, the veterans, and our foster care. I think I heard that there was a preliminary or temporary injunction for the Planned Parenthood. Are there any considerations for any kind of legal injunctions for these specific populations as well?
I'm not aware of there being legal challenges to those changes and exemptions, though the department may have more information on that.
Okay, thank you. I appreciate it. Thank you, Mr. Chair. perfect.
Thank you, Mr. Chair. Thank you, Mr. Chair. I wanted to go back to the SNAP benefits and the work exclusions, work requirement exclusions. On, I guess it's marked as page 8, you have a number of 29,705 cases from May of 24 to 25 of folks that those cases were closed due to the failure to meet those work requirements. And that's before the big bill, correct?
Yes, there were, I would say that the work requirements have kind of largely not been enforced due to available exemptions and COVID-related delays. So that does pick up some kind of new implementation after the end of some of those suspensions and ability to use exemptions to delay the impacts, and also the end of some waivers in particular jurisdictions, including Baltimore City would be the largest of the jurisdictions that also had a waiver. So it's picking up some of that kind of new implementation of that as well.
Okay, and so just a little back of the envelope math, on the total number of SNAP recipients that you've provided here, and that's around 665,000 people, correct? Mm-hmm. That's about 5% of folks that before the big beautiful bill that were excluded due to work requirements. Is that about right?
Yeah, the caseloads were a little different at the kind of the earlier period of that, but yeah, about 30% do return at some point based on the data we have, but yeah, so at least some loss of benefit.
Okay, and that was one of my other questions was what were the reasons for those cases that were closed and then revisited or I guess reopened?
So reasons that the case could be subsequently reopened would be that they demonstrated that they qualified for an exemption, or that they began to comply with work requirements. So if they were meeting work requirements again, they would then become eligible.
Okay, and then so just under that time frame before the big beautiful bill, if that trend carried on just under those percentages in Baltimore City, we would see about 7,000 or so odd people be excluded from SNAP benefits based on the trend of not meeting work requirement eligibilities. Is that your take, or would you agree with that?
I would say that I would expect kind of the initial implementation of it to have the highest impact, and then over time it does tend to level off. After that kind of first round, the numbers become smaller. So in this kind of initial phase is when you would see the biggest impact, but I don't know exactly what we would expect to see kind of overall. We do have some kind of broader estimates kind of across the state, but not specific by jurisdiction.
Okay, thank you.
I didn't have my microphone on. Welcome to you all. And Ms. Fabian Marks, you're on. Welcome. And Michelle Eberly as well, if we can pull her up. Whichever one of you wants to kick off, you can start.
Wonderful. I will kick off. So good afternoon, Chair Barnes, Vice Chair Kaiser, and committee members. Thank you.
You're good. We can hear you. Oh, shoot.
I'm here. Can you hear and see me?
Yes, we can.
Okay, beautiful. I will start. Thank you.
Yep, go ahead. We can hear you. You're in great shape.
Okay, very good. I might be getting some feedback on something I have here, so let me.
Make sure if you had it on YouTube or whatever it is, make sure that's off because it'll feed back on you.
That's what it's doing. All right, so I will go from here. Good afternoon, and thank you, Chair Barnes, Vice Chair Kaiser, and committee members for giving us the opportunity to be here today to brief you on Maryland Health Benefit Exchange and Maryland Health Connection. We greatly appreciate that you've given us this opportunity to be remote. We have our Board of Trustees meeting, which starts today at 2 o'clock, so appreciate this flexibility. I am, for the record, Michelle Eberly, the Executive Director of Maryland Health Benefit Exchange, and I will be going over today a little bit on our open enrollment results. We just finished open enrollment on the 15th, and I will talk about the impact of HR1 OBA on the marketplace, and then I'll turn it over to Johanna, who will talk about the state subsidy program impact on the exchange for Medicaid, OBA, HR1 work, and then also the reinsurance program. So just to level set, I know you all know this, but we are an independent unit of state government established in 2011 in accordance with the Affordable Care Act, which was passed in 2010. The Maryland Health Benefit Exchange is the state's designated marketplace. We operate Maryland Health Connection. We are the only source of financial assistance for people in the individual market through federal subsidies, premium tax credits, and through now the Maryland State Premium Assistance Program. We serve over 1 in 4 Marylanders, 222,919 enrollees in the individual market as of December 2025. And I'll talk about 26, which are better numbers, and then 1.2 million MAGI Medicaid enrollees. The vision of the exchange is high quality, affordable health insurance for all Marylanders. We support small businesses, and we also provide standalone dental and vision plans. On the left there is, you can see the video, you can link into that at your own leisure. Shelley Eldridge, who actually is one of our enrollees, and during the pandemic, when she lost her job, she wanted to start her own business and was not sure she'd be able to do that because of healthcare. She was able to purchase on the exchange, has continued to be enrolled through the exchange, and has become a small business owner in the state of Maryland. Next page, please. Next slide. So open enrollment, we just finished on January 15th. Our goal this year was to retain as many enrollees as we could. A big part of that was the state premium assistance program that you all had a hand in helping us achieve last session. And that was a game changer for keeping people enrolled. And again, our goal was to keep as many people enrolled. Our enrollments, we ended up a little over 3% of new enrollments, which sounds great. You're going to hear coming out of the federal government a lot of talk about that enrollments are up, which is good news. And there will be some talk about not having the expanded tax credits to not affect enrollments at all. This year, what's important is to really drill deeper into what is the true story of those enrollments, and I'll talk about that. You can see our new enrollments were down significantly. Our renewed enrollments were up, and that's because we came off the public health emergency unwind from last year where we started at a higher level. And then, of course, our disenrollments are significantly up. What we found, if you look over to that little right graph, you'll see that consumers that were enrolled without premium tax credits or advanced premium tax credits, that's up almost 43%. A large chunk of that is those that are under 100% federal poverty level that are lawfully present immigrants previously allowed to use tax credits. Many of them are over age 65. And they did not work in the system long enough to get Medicare. So that's a very vulnerable population. Those with premium tax credits are down almost 9%. Next slide. Drilling down deeper, this is the important message of the year. We did achieve our goal of maintaining retention as much as possible. However, what we found are the rising premiums drove consumers to higher deductible, less comprehensive plans. And in fact, our enrollment shifted significantly from gold to bronze health plans. And to put that into context, that is going from a $1,000 deductible health plan to a $10,000 deductible health plan. So now consumers have had to take on additional financial burden for their healthcare costs. And more alarming, where we saw that big shift from gold to bronze, is in consumers that are over age 55. So again, either higher earners, did not qualify for the state premium assistance, or pre-retirees. We know they're in that category. It was 31% of our total of that gold to bronze. The second biggest chunk we saw was people moving from gold to silver. And those, again, we saw age 45 and above was our biggest chunk of folks in that. That's a 53% of that. So people are taking on more financial risk. They have very high deductibles, especially in those bronze plans. These are the folks that we know will defer treatment, or they'll wait until they're so sick they'll go to the emergency department and secure treatment. The other item to note, and I keep trying to mention this when I'm out and about, is that the loss of the enhanced federal tax credits is actually increasing the consumer's federal tax burden, because when they could use those taxes to help them purchase health coverage, it lowered essentially their tax burden. We won't know the full disenrollment impact until about March or April, and that's because when people enroll or re-enroll in coverage, if they don't get any financial or premium tax credit, they have 31 days to make their premium payment, and carriers cannot terminate them for those 31 days. If they are receiving premium tax credits, then they have a 90-day grace period to make that payment. So we won't know the full story until people don't make their payments. They may make that payment for 1 or 2 months and then really decide, gee, you know, my car insurance went up, my electric bill has gone up, the cost of food has gone up. I have to pick something. I'm going to let the health insurance go. So we'll report back once we know that full impact. Now, Maryland fared better than most states in the nation. We know that, as Speaker Pena-Melnick said, we were one of the only states to do this premium assistance program. After the fact, other states came in and did some additional funding through their legislatures, but we were ahead of the game. However, what's important to note is that this state premium assistance program is not sustainable long-term. It's funded out of the reinsurance fund. We know that the reinsurance program ends the end of December 2028. And we also have the reinsurance program that we are funding, and we do not want to destabilize. Next slide, please. Now, a little bit about the H.R. 1 changes to the marketplace. We actually had 3 things come down last year. We had a program integrity final rule in June, then OBA H.R. 1 in July, and then the expiration of the enhanced premium tax credits. All of these rules made enrollment more difficult, restricted eligibility, and reduced affordability options. And again, we know the outcome of that. We just went through our open enrollment numbers. Next slide, please. So the marketplace changes in the end of December or the end of September, we did have to terminate coverage for 300 DACA recipients. This is the most heartbreaking story of all of the immigrant impacts, because there aren't other options. And so these are folks, particularly those mid health plan year, that just abruptly lost their coverage. We saw the first change for the lawfully present immigrants impact January 1st. And as I said, many of those were under the 100% FPL that had not been here long enough to either get Medicaid or may have not qualified for Medicare. We had 1,465 enrollees that terminated coverage because under that 100% FPL. We will see a second impact coming January 1st, 2027. Again, more immigrant related. We anticipate about 20,000 additional Marylanders might be impacted. And then we will see those same limits for Medicaid coming at the end of October 26. The other thing on the horizon for Marketplace is the enrollment dates will change for next year, now effective November 1st through December 31st. So we're going to lose about 2 weeks of the enrollment period, again, just creating additional burden for those looking to get health coverage. Next slide, please. We talked about this again, without those premium tax credits being renewed, the cost of enrollment, where we see enrollment, where we saw an increase, and now where even though we did not lose what we thought we were going to lose, we know what the financial burden is going to be for those consumers. And I will stop there and turn it over to Johanna, Fabian, Marks to take it from here. And I will hop off for our board meeting. Thank you.
Thank you so much. And I assume Johanna can answer any questions we may have had for you.
She can.
Okay.
If not, we can certainly get back to you.
Okay.
Thanks.
Appreciate you. Yep. Good luck with the board meeting. Thanks for being with us.
Bye.
Hello, can you hear me okay?
Yes, we can. Thank you.
Great, thank you. We can go to the next slide. All right, so I'll briefly run through a little bit more information on our state premium subsidy, one of our major responses to the affordability challenges that occurred with the loss of the enhanced premium tax credits. So as Michelle noted, and as DLS mentioned, the state took decisive action to protect our residents from premium increases driven by the loss of federal premium tax credits. By establishing the premium subsidy program, this program fully shields individuals earning less than 200% of the federal poverty level from premium hikes. So that would be individuals earning less than about $31,000 or a family of 4 earning less than about $63,000. And then for enrollees above those income levels, up to 400% of the federal poverty level, we were able to replace half the value of their lost federal financial support. In addition, young adults get extra premium savings because we folded our existing young adult subsidy program into this overall premium subsidy. And briefly, I want to cover how the subsidy works. Individuals do not have to specifically apply for it. We assess their eligibility when they are enrolling, automatically show them the savings, and apply it to their premiums. So our goal was to minimize the friction to the enrollee so that it could work as intended at keeping people in coverage. The subsidy, as Michelle mentioned, is funded by the state premium assessment, which also supports the reinsurance program, and I'll discuss that more in a moment. Next slide. So here is a snapshot of data as of the end of our open enrollment period on the 15th. We have over 177,000 individuals receiving the state subsidy at an average amount of about $94 a month. But as has been noted, this is still preliminary data because even with the state subsidy, we do expect to see an increased number of people not paying their January premium and dropping coverage. So we'll be keeping close tabs on this data as it evolves. Next slide. And then just to briefly describe in other terms the impact of the state subsidy. So these are projections that we put together last August, and these projections and the initial data from the close of open enrollment indicate that the state subsidy is having a major impact keeping people enrolled and stabilizing the individual market. Without the state action, we projected that our 190,000 enrollees losing the enhanced federal tax credits would experience a 95% premium increase and 90,000 would drop coverage. With the state subsidy, that net increase fell to 35%, still significant, but we project that the state action cut the number of individuals who would have otherwise dropped coverage by 2/3. As I said, this data is still evolving, so we'll continue to track this, but the data so far does bear out the success of the subsidy program. Next slide. All right, I'm going to very briefly discuss HR 1 and its impact to the exchange. I won't spend a lot of time to this as DLS already spoke to it and MDH will further address its impact to Medicaid. But I do want to briefly address the impact to MHBE's operations. People aren't always aware of the major role that the exchange plays in Medicaid. We enroll individuals who qualify for Medicaid on the basis of income, known as Modified Adjusted Gross Income or MAGI enrollees. So that means the exchange enrolls 85% of Medicaid consumers, about 1.2 million individuals, including the ACA expansion adults affected by work requirements. Our support to these enrollees includes developing and maintaining our enrollment platform, Maryland Health Connection, where individuals get their eligibility determination, enroll in managed care organizations, submit documents to verify their eligibility and renew coverage. We also operate a call center to assist our applicants and enrollees. We manage printing and mailing notices and Medicaid cards, handle appeals of eligibility determination, and train consumer assistance workers. We fund the majority of these services out of our MHBE budget. Next slide. So this is just another recap of the major eligibility changes under HR 1. MHBE will be implementing all of these for affected enrollees, and we do anticipate a significant impact on our operations as a result. Last slide, or next slide. So fortunately, the exchange has a lot of experience using technology to streamline operations and reduce consumer burden. We already work with a number of different entities to leverage available data to verify eligibility. For example, we already use SNAP data from Department of Human Services and data from the Department of Labor to streamline enrollment in Medicaid. We know how to set up data exchanges with other agencies, and we're building on that experience as we work to implement these changes and minimize impact to enrollees, of course, in close partnership and under the guidance of MDH. We're also going to responsibly and strategically leverage AI to increase efficiency and manage operational costs. Again, we'll be building on our existing use of AI. And I do want to note that we are a leader among state exchanges on this front. We've already deployed an AI-powered chatbot to help our users as they're enrolling. We use it to help save costs from our call center by providing automatic support to individuals to reset their passwords and check case status. And we leverage robotic processing to scan and verify documents uploaded by our enrollees. Next slide. All right, and moving on, I will briefly cover our reinsurance program, and this is the last item in our presentation. The General Assembly put the reinsurance program in place in 2019 to stabilize the individual market. As you can see in this graph, prior to 2018, the individual market was seeing double-digit premium rate increases. Once the program was put into place in 2019, we saw significant rate decreases in the first few years, then moderate increases in line with trend thereafter. Unfortunately, we did return to low double-digit increases in 2026 due to the federal changes that have been discussed, but that increase was still significantly lower than many other states saw. In total, the reinsurance program reduces premiums by about 30% relative to where they would be absent the program. Next slide. Here you can see how the implementation of reinsurance stabilized enrollment. Again, you can see prior to 2019, our total enrollment was falling. Once the reinsurance program was implemented in 2019, enrollment stabilized and began to grow. So it was having the desired impact. Next slide. A brief 101 on how the reinsurance program works. Through reinsurance, the state reimburses insurers for a portion of their claims cost. As I mentioned, the program covers about a third of insurers' claims costs, which allows them to reduce premiums by about a third relative to where they would be absent reinsurance. We operate the program under a waiver from the federal government, which is approved in 5-year increments and expires at the end of 2028 currently. Next slide. So how do we fund it? First, we use state funds derived from a 1% assessment on most state-regulated health insurance. The feds had a similar assessment that ended in 2018, so the state stepped in with an assessment in 2019. And in addition to the money that comes in each year through that assessment, we have a reserve built up in the first several years of the program, which occurred as a result of a higher assessment in 2019, which allowed us to bank some funds. And in addition, we received higher than expected federal funding in the early years of the program. In addition to the state funding, we receive federal funding from the federal government under the terms of our waiver. That funding varies each year. It's tied to the Fed's calculation of how much money the reinsurance program is saving the federal government. Next slide. All right, here is a chart that depicts the annual funding that's coming in to support the program. Green shows federal funding, blue shows the state funding. The red line shows the annual cost of the program, and the purple line shows the state reinsurance fund balance. You can see that purple line, the fund grew in the early years as costs came in below the total funding, and we were able to build up some reserves. And you can see that this year we'll be drawing down on those reserves to support the state subsidy program. I do want to note the 25 and 26 costs are projected, as are the 2026 funding numbers. And then my last slide is regarding the future of reinsurance. As we've mentioned, the current waiver from the federal government, as well as that 1% state assessment, sunset at the end of 2028, absent state action. This year, our board will be closely monitoring the state subsidy program expenditures and will continue closely monitoring reinsurance. Taking all of that info into account, the board will set 2027 reinsurance and premium subsidy levels, considering available funding and the importance of maintaining the solvency of reinsurance through the current waiver period. In addition, in 2027, the state will need to determine whether to apply to the federal government to extend the reinsurance program and whether to continue the assessment that funds the state share of the reinsurance program. Lastly, the state premium subsidy is only authorized through calendar year 2027. So overall, in 2027, we'll be looking at a conversation within the state about how we support health insurance affordability broadly going forward. And that concludes the exchange's presentation.
Thank you so much. Great presentation, and thank the director for us as well. I want to ask a question about one of your first slides that the director gave us, folks moving from gold to bronze. I thought she gave us a number, but I didn't write it down, and I went back to the page. How many people moved from that gold to bronze? Do you have that?
We will follow up with you with this specific number. It was several thousand.
It's significant because, look, I mean, people going from a $1,000 deductible to a $10,000 deductible, there will be no wellness visits. There will be no, regular doctor visits. And to the extent that they hit a catastrophe, for a family like mine growing up, look, it didn't matter if you were going to give us a $10,000 bill or a $100,000 bill. We weren't paying it. We just didn't have it. So this population to me seems de facto uninsured. And so, I think it's really a tragic consequence of probably won't get as much media or attention as it deserves of these actions, these federal actions. Other questions? Delegate?
Thank you, Mr. Chair. I just wanted to go back to the renewed enrollments that are up by 7.7%. You mentioned, but I think you mentioned that the renewed enrollments are going to further decline after the delayed impact of the automatic renewals hits where they are canceled for non-payment of premium, correct?
That's correct. That's our expectation.
So in your number there, 207,797, there hasn't been enough time for any cancellations for non-payment of premiums. So that could be significant additional non-renewals.
Yes, we are concerned about that and we'll be monitoring it.
Okay. Thank you.
Thank you. Yeah, please, as you get this information, as it rolls in, if you can update the committee as you get it, especially if you get it during session so we can analyze it. Vice Chair.
Thank you, Mr. Chairman. Thank you for this presentation. I had a question from page 16 where it referenced the AI-powered chatbot. On the first part, I'd love to hear more about how you tested it and everything else. You ended that part by saying that it should have reduced calls that might have otherwise resulted going to your call center. And I would presume you would have data that could look at that and show that call center calls decline. So I was curious why that was a little more vague there and what more you could add. Thank you.
Yes. So regarding the chatbot, we did construct that very carefully. It only was trained and draws from information that is in our website. So it's a closed model, and we're confident in its reliability. Regarding the savings, we'd be happy to follow up with an additional numbers. We just launched in December some of the features, and so we're still calculating some of those savings impacts.
Doug Chetty.
Thank you, Mr. Chair. Thank you for the presentation. Can you remind us, please, the categories of individuals who are no longer able to enroll for plans on the exchange?
The only individuals that are barred from enrolling through the exchange are individuals who are not legally present and now newly DACA enrollees. However, we did have approximately 20,000 legally present immigrants who lost eligibility for financial help. They can still enroll in full price plans, but they're not eligible for any help paying for that, which is a major impact because they were all legally present immigrants who are below 100% of the federal poverty level and either have not been in the U.S. for at least 5 years, which once they're in the U.S. for 5 years, they can be eligible for Medicaid. But in that waiting period, they were getting financial assistance through the exchange. In addition, it can include individuals who are legally present immigrants over the age of 65 who aren't eligible for Medicare. So that's the population that was impacted. Pregnant individuals and children are not among those individuals impacted.
Okay, thank you. And then sort of a related question, if they're not able to get coverage through the exchange, where can they get coverage or how can they?
If they can't afford to enroll through the exchange, they can seek enrollment through federally qualified health centers or seek to use hospital assistance programs, but their options are certainly more limited than if they have access to insurance coverage.
Thank you. And the total number again of all of the people we're just talking about across the state?
About 300 individual DACA enrollees lost eligibility entirely, and about 20,000 legally present immigrants lost eligibility for financial assistance.
Thank you.
Okay, thank you. Thank you so much for your work. Thanks for being with us. We'll look forward to additional data and information as you're able to collect it. Thanks.
Thank you.
I'm going to now move to MDH, Deputy Secretary Briskin, and I think Mr. Baker is going to join at the desk as well, so welcome.
Mr. Chair, Madam Vice Chair, Jeremy Baker, Governor's Chief Legislative Officer. I'm joining you here today because we want to show the response from the administration is not from any one department or agency, but is across all departments and all agencies as we work together to implement and mitigate the effects of H.R. 1. I'm going to call it H.R. 1. I feel like OBA feels like a really friendly name for something like this. So H.R. 1's a complex bill driven by ideology, crafted and amended to get votes for its passage. In Maryland, we've made incredible progress towards building an accessible and accountable public benefit system that promotes health and economic opportunity for hundreds of thousands of Marylanders. I want to focus on 3 cornerstones of our state response to H.R. 1. The first is mission alignment. Every agency you hear from today is focused on the same core mission, minimize harm and preserve lawful benefit access. They are all committed to the same shared values, being human-centered, accountable, and transparent, and protecting the most vulnerable among us. We're committed to a response that meets this mission, honors those values. For example, we've launched a regular data-driven meeting with all the agencies and the governor's office to oversee implementation. We've had a ton of conversations with the subcommittee chair, members of the committee, members of HGO, BNT, et cetera. The second's innovation. It creates a new opportunity and a front for us to stay nimble and innovative. Our success around reducing the SNAP error rate from 35% in 22 to now 13.5% in 24 is a great example of this approach. A couple of things I want to highlight. First and foremost, we did this by reducing agency vacancies for that eligibility staff from 15 to 4%. We implemented new eligibility and enrollment data management systems that addressed over 3,000 previously undiscovered system defects. So it's been a ton of work to make improvements to get where we are at the moment. Moving forward, we're going to continue to be innovative, leverage new tools, and continue to explore every option to making sure as many Marylanders as we can have access to these benefits. Lastly is our partnerships. This means, again, as I mentioned, partnerships across agencies, across state and local governments, additionally the private sector. Obviously, there's a ton of overlap between SNAP and Medicaid as it relates to things like eligibility. So we're making sure that all the systems talk to each other, and we continue to leverage best practices of what we see elsewhere, and are also talking to private sector opportunities for how we can improve that process. So it is an all hands on deck approach. Tomorrow we'll share you the full accounting of that effort as it relates to our FY27 budget. I'll finish with this. No state in the country can afford to supplant the role of the federal government in these programs and account for the full impact of HR 1. Working together with you guys, we're going to do the best job that we can to minimize every impact that we can with every dollar that we can used in the most effective way possible. And that's our commitment and the effort that we've been undertaking so far. And we look forward to continuing that work together. With that, I'll turn it over to Perry.
Thank you. Good afternoon, everyone. My name is Perry Briskin, Deputy Secretary for Healthcare Finance and Maryland Medicaid Director. Thank you, Chair Barnes and Vice Chair Kaiser, for having me here today to talk about this important issue. I am sticking with OBA. I like OBA. I'm going to keep it. So I'm going to be repeating a few things that you've heard from other people prior to me sitting here, and just really quickly reviewing what are we talking about when we talk about Medicaid changes. So the first and coming up the quickest is changes to immigrant eligibility. So we estimate about 15,000 Marylanders will no longer be eligible for coverage due to their immigration status starting October 1st, 2026. Medicaid work requirements go into effect January 1st, 2027. That impacts the 320,000 non-disabled adults who are in our ACA adult population, as we call it, and we estimate up to 115,000 of those individuals could lose coverage, not necessarily because they're not eligible, but because of red tape of jumping through all the new hoops. In addition, and as or more significantly than the work requirements, is more frequent redeterminations. So currently, everyone in the state of Maryland goes through redeterminations every 12 months. For these individuals, it will now be twice a year, every 6 months. And we know in Medicaid, when you go through redeterminations, you often churn out, as we say. You lose your coverage. Again, not because you're not eligible, but because it's hard to get through that red tape. There's also a shortened, what we call retroactive coverage opportunities going into effect January 1st, 2027. So it reduces the amount of time from the point you start enrollment that we cover your medical costs backdated. So it used to go back 3 months, and now it's just 1 month of retroactive coverage for those ACA adults. And that's a measure that many states have to protect against medical debt. There are a series of other OBA provisions related to Medicaid in the statute. I will be going over provider taxes and state-directed payments here, but happy to talk about any of these if folks have questions. In total, we could see as much as $2.7 billion in annual federal funding being lost to the state once all the provisions over the many years of OBA are implemented. The majority of these funds are from a mix of the provider taxes, the state-directed payments, and the loss in eligibility. For this ACA coverage group, we get a higher federal match, so they're funded at 90% instead of the 50% of many of our other populations. So when those folks lose coverage, we lose a lot of money. So this is just a high level of provider taxes. So these taxes help pay for about $2 billion in Medicaid costs in the state of Maryland. Provider taxes are a financing mechanism where you can tax a class of provider. You collect that money from all providers, a broad-based tax. You pull down additional federal funding with those dollars, and then you can distribute that for Medicaid specifically. So it's a way that we all pay into the system to better fund our Medicaid population. And we have 3 provider taxes in the state of Maryland: a hospital, HSCRC hospital tax, a managed care tax, and a nursing facility tax. I think which Anne had mentioned earlier, the taxes are within the percent range of percent of revenue, but where it's tricky is that our taxes are not broad-based, and this statute requires it to be broad-based. So what the new statute is really pushing states to do is you have to tax all providers in the class. We have a few exceptions for that. For instance, for hospitals, it's only taxing HSCRC hospitals that participate in the model, not all of our hospitals. So CMS may come back and ask that we do a broader tax to make it broad-based. But we are still most importantly, waiting for additional CMS guidance here to fully understand the impact. State-directed payments, we have 3 state-directed payments in Maryland, and 2 of the 3 relate to primary care under our HUD model, so those are not impacted, those are exempt. And then we also have a state-directed payment that supports the University of Maryland medical system. We are also waiting for additional state-directed payment guidance from CMS. Moving along here quickly, a little bit on work requirements. This is a high-level overview of what the Medicaid work requirements look like. Have income at least 580 a month, 80 hours of work per month, 80 hours of a SNAP-defined work program, et cetera. So our goal here is to really take advantage of all the flexibilities, the technology, the resources that we have here in the state to maximize work requirement exemptions and mitigate coverage loss due to the work requirements. This is a little bit about the exemptions, which get a lot of attention. And so there are many exemptions in the statute. We see CMS putting out guidance on this, specifically the medically frail definition. CMS uses existing definitions in federal policy for medically frail, but these are some examples of if you have any of these conditions, you would be exempt from reporting work requirements. This is an example where CRISP data will come in handy. If you have been to see a doctor and you have been diagnosed, then this would hopefully come up in CRISP data, and we could automatically note that you're exempt from work requirements. This is an important slide. So this tries to look at, we've asked our partners at Hilltop at the University of Maryland to really get a sense of the current population and how many people we think actually would not be eligible for Medicaid due to them not working, not being in school, not being exempt. So we think the vast majority, 90 to 85% to 90% of individuals, they are either working already, they are either in school already, full-time or part-time, or they would qualify for the exemption. So the number of people in the state of Maryland who would not qualify for Medicaid due to not being eligible for work requirement or not making the work requirement meet it is quite small. It's only about maybe like 30,000 individuals. So we need to, one, make sure that that 85 to 90% get through the system, don't lose coverage due to red tape. And then for that 10 to 15%, reach them with the work that they would make them eligible for Medicaid, whether it's work, whether it's job training, whether it's community service, to make sure people who are eligible can stay covered. This is to show the enrollment impacts. We don't expect to see the majority of the disenrollments of people losing coverage until middle of calendar year 2027, start of fiscal year 28. And that is because that is when the 6-month redeterminations kick in. So it's not till the middle of 2027 that you see both the 6-month redeterminations and work requirements fully kicking in, and you will start to see individuals losing coverage. A little bit about our implementation. We are taking a cross-agency, cross-state approach, working on data and systems, staffing, and communications. As MHBE shared, they are a significant partner for us, so they sort of work as our extension of who processes the majority of our applications and renewals in Medicaid, and including this ACA adult group. We are on track for implementations. This is just a little bit behind the curtain on our data and systems implementation. And we are currently working on specific work requirement and exemption implementation. Important dates to highlight on this slide: by August 2026, we will be doing testing of the work requirements, new portals, new interfaces for people to log in and for our team to test. In government, August is not very far away from now to build and start testing a new system. Also important in August, the notices to individuals who will be impacted by work requirements will start to go out, and that's a federal requirement that we have to start getting notices out to folks. So this is just an enormous amount of work for all states to do very, very quickly. And then October 1st, 2026, the immigration eligibility changes go into effect, and then January 1st, 2027, the work requirements and more frequent eligibility changes go into effect. I think as MHBE started to mention, we are leveraging data across the state, whether it is SNAP data, Department of Labor, CRISP, Department of Education, Comptroller. We are trying to turn over every data rock to see what we can leverage here to make work requirements as automated as possible. It will also be not dissimilar to Medicaid unwinding, for those who remember unwinding, a heavy communications approach. So working with partners to get the word out to all members of Medicaid. We also are concerned about a chilling effect. We don't want people who are not impacted by work requirements think they're subject to work requirements and not return their paperwork. So we have a large communications campaign that we're working on, modeled off of unwinding, if you remember the Medicaid check-in campaign. So we have contracted with an outside organization to partner with our managed care organizations to relaunch this campaign. We've also created a dashboard on Hilltop's website to show where the ACA adults are, so you can check in your county how many of these individuals that are going to be impacted live there. Also, as Jeremy mentioned, it's all hands on deck, so meeting regularly with stakeholders in sort of more of a grassroots sense to know how can we support individuals, learn about these changes, and get through the system. The message for individuals is similar to unwinding. Keep your information, your contact information up to date in the system, in the MHBE system, so you can be aware of any changes. This is on our Hilltop website. This is our ACA Adults public dashboard, and we hope to expand this with more data. We will be needing additional staff to develop training materials, to do additional eligibility processing. Currently, just over 50% of people get auto-renewed through Medicaid, but that's another 50% who require manual processing. So we will need new staff for that. And so we're hoping to have sufficient resources to implement this. And that is the end of my presentation. These are some resources we have publicly for both policymakers and consumers on our website, and happy to take any questions.
Thank you so much. Thanks for being with us. Thanks for your work. Any questions for the Deputy Secretary? Delegate Rice.
Thank you, Mr. Chairman. Just one comment and then a couple of questions. I just want to comment on the initial statement that Jeremy made about the HR1, being passed to garner votes. And typically, I normally responded because it's a partisan statement. And, the same.
Jeremy's, Mr. Baker's a witness. He's not a member. So typically, I'll let you respond.
I understand, but he also represents the department.
Let me make it brief, Delegate. Go ahead.
Thank you. And typically, I won't. But the same can also be said for having a very robust safety net program for folks who aren't residents of the country. Can be also said that we're doing this specifically to garner votes too. And I would never say that, but some people do. And I'm only mentioning that because it's already been said. But moving forward with questions, hopefully that are productive. The first question I have is in regards to our federally qualified health centers, FQHCs. Do they turn anyone away either for ability to pay or for their immigration status in Maryland in practice?
So currently, no. I know they're under significant pressure by the current federal administration, and I don't think they've received full guidance, but that's something we are concerned about, is if these individuals lose Medicaid coverage and are uninsured, and federally qualified health centers are barred from treating them. I think the only place for them to go, one of the few places, is the ED. But I don't think they've received full guidance.
So in practice in Maryland, every single Maryland person who lives here, whether they're Maryland residents or not, have access to well visits at a federal qualified health center, correct?
Yes.
Practice, yeah, they do. And then if someone is in an emergency situation, none of our ERs can turn anyone away for ability to pay or for immigration status, isn't that
correct? Under EMTALA.
I just wanted to verify that. And I know that, we're focusing on the affordability of healthcare, and that's a challenge not just for our state, but across the country. And obviously it's a complicated question because this is a complicated issue, but the cost of healthcare is a big problem. And so is the department, are you guys well enough organized where you could brief us and the health committee as well on ideas on how we can reduce just the overall cost of healthcare in general?
Thank you for that question, Delegate. Yes, I believe we are happy to brief the committee, and we are preparing presentations for later this month and overall sort of what's the status of Medicaid, why is it so expensive, what are the top cost drivers, and so we're happy to have that conversation.
Sure. Very good. That's the last question. Thank you.
And I think Delegate Rice does a good job of shining a light on uncompensated care. And I wanted to know if you could sort of expound on sort of the ramifications on uncompensated care, what happens to providers who are forced into those situations?
There are no easy, thank you for that question, Chair. There are no easy answers to that, to be honest. If individuals lose coverage, whether it's uncompensated care at our federally qualified health centers or at our hospitals, that is an increased cost to our providers and could lead to some providers not being able to sustainably deliver care. And we don't want to create access issues for providers having to close. We plan to stay engaged with community partners to see what they're seeing on the ground to assess that need. And we would and so we'll continue to monitor the situation, but there are no easy answers there.
Thank you. Appreciate it. Thank you, Delegate. Delegate Shetty.
Thank you both for being here, and thank you for the presentation. Can you clarify really quick, just because I really appreciate the conversation on uncompensated care, how many FQHCs do we have in Maryland?
Oh, I would have to,
I think it's like between 21 and 24 is what I'm understanding. So do you know, like, one FQHC couldn't possibly serve, like, how many people are currently underinsured or now projected to be uninsured based on this?
130,000 individuals.
Okay, and so the expectation is that 21 to 24 facilities would be able to provide primary care, and essentially dental and behavioral health, which is what our amazing FQHCs do for 130,000 people. Or they go to the ED.
Yes, that would be a high ask.
Okay, got it. Thank you. And then the other question I had was, actually my question was very specific to, was related a little bit that I had pre-drafted, but it was about the disenrollment by county information that we got. I think sometimes it gets really easy to get lost in just the financial figures here and the federal government impact on our budget and all the budget numbers, but I always like to think about the people, right? So we pulled a couple of statistics from the DLS slides. So page 19 of their briefing slide said, and you don't have to look at it because I'll just tell you, 5,326 people projected disenrolled from Washington County, 4,242 people from Wicomico, Eastern Shore, and then, hold on, yeah, I had some more. So you see, like, there's a pretty substantial impact to our Eastern Shore and Western counties, and many of them already have difficulty accessing healthcare services, right? Like, there aren't as many hospitals in those areas. There aren't as many providers in those areas. And sometimes our patients have to drive a pretty far distance to get to them. So what could this disenrollment actually mean for the people who either remain covered in those areas?
So I think it raises costs for everyone. So when you have a spike in uninsured individuals and a spike in uncompensated care, it raises healthcare costs for everyone. You sort of just squeeze the balloon to those who still can pay.
Right. And then what about, like, wait times for services in the few hospitals that they have access to? Would they be impacted?
I would imagine those wait times would go up. Maryland has some of the highest ED wait times in the country already.
Right, and we're seeing some good progress. I literally just met with HSCRC right before walking into this briefing, so I know we're seeing some good progress across the state on some of those metrics, but I imagine that some of that progress will likely reverse when disenrollments fully hit. So thank you for this data. Appreciate it.
Thank you, Chair.
Thank you, Mr. Chair. Excuse me. So I did have a question about uncompensated care, so thank you all for covering that. And also about the disenrollments for this approximate 115,000 that could possibly lose coverage and where it's going to be mostly impacted. So I'll turn my question to something else. On communications approach, I know it's going to have to take a lot of redundancy to get the messaging out. For those populations that's going to be impacted, I see that on the timeline, you start sending out messaging in August. And then how often will messaging go to those folks? How will they be expected to, for you all to reach those folks starting in August, and the disenrollment that only gives us 4 months, January 5, to get it out to them. And then my second question is, for those folks who become disenrolled, is there an appeal process, or is it just automatically it's done and they have to start over?
Thank you, Delegate, for those great questions. So to answer your first question, when people go through a renewal, we send them a letter in the mail. That is a federal requirement that we have to send them a letter in the mail. So there's that formal communication that goes to them, but then we're hoping with this communications campaign and working with community-based organizations that there will be other touch points to reach them with information.
Okay.
But what goes out in August is that formal communication that we are required to under federal rules. In answer to your question about appeals, there will be an appeals process. I think that's what we need to work through and understand what the requirements of that appeals process are from CMS, because that is a brand new process on if you get disenrolled as a result of the work requirements, how does that work? But that is another book of additional administrative work for the state to manage what's expected to be an increase in appeals.
Okay, and last question, will that all be on the dashboard of the process of appeals and, how folks can navigate through that?
I will have to check with the team, but I will make a note of that and we can get back to you.
Thank you. Thank you, Mr. Chair.
Thank you, Delegate.
Thank you, Mr. Chair, Mr. Baker, and Deputy Secretary. Great to see you guys. I was encouraged to see the slide talking about the increase in hiring that would be necessary based on the increased intervals for redeterminations of eligibility. And I was wondering, are those staffers the same folks that deal with appeals or requests for reconsiderations on determinations of eligibility?
Yes, we are requesting additional eligibility staff, and it will require, necessitates enhanced eligibility staffing and a new staffing plan, but yes, all within the eligibility realm.
Right, so my question is, the folks that would be doing the determination of eligibility, are they the same people within your department that then review appeals of denials?
Thank you, Delegate, for clarifying. No, those are separate teams.
Okay. What are the difference in those folks, I guess?
So we have at our local health departments eligibility workers who verify eligibility for those people who are not auto-renewed. The appeals team, which accepts appeals and processes appeals, that sits not within our local health department, but within our Maryland Department of Health. And if you like, I'm happy to get more details on exactly the different skill sets and how they each operate, if that would be helpful.
No, I think that's great. I would also, I think we should add, in addition to further staffing for vetting, this increased vetting of redetermination of eligibility, considerations on the appeal side as well, because it seems to me that it's going to create more denials, right? Or potentially create more denials. And I believe you remember that I've emailed you recently about a situation in my district where a bedridden woman had been waiting for over a year to get a reconsideration of her denial of a community option waiver. And that is still in the process of being handled right now. And so I think that that's only going to be exacerbated by this increased intervals. Would you agree with that?
I would, Delegate, but I would like to make one important clarification. The team that we have, the renewals for the people with disabilities, which is what I think everyone in this room has received a question from a constituent. Where is my waiver application? Where is my waiver renewal? That team and those systems are separate from the individuals who will be going through work requirements. They both have their own unique challenges, and as I say, any one cut to Medicaid is a cut to all of Medicaid because it stresses resources in the same division, but those are separate teams, and so the additional work of this shouldn't impact the waivers. The additional work of the work requirement shouldn't impact the waivers, but the waivers need, and that can be a whole other discussion, which I'm happy to present to the committee on, but we are doing a lot of work to improve our waiver eligibility processes separate from all of this OBA implementation. So, but I do want to make sure they are very different teams and different requirements.
Okay, thank you.
Sure.
Thank you, Mr. Chair. Back to the issue about people don't have insurance, and so they go to the emergency room or a federally qualified health. Do we track those costs? I mean, do we know what those expenses are and what that adds up to on an annual basis?
Thank you for that question, Delegate. Yes, I believe our hospitals and our health centers track uncompensated care costs.
But do we roll that up at the state level so that we know how big that nut is that we have to deal with?
I believe we do. I would not know, but we can get back to you on that. And I absolutely believe our partners at the HSCRC would have some of that information.
Okay, thank you. One, if I could, just a quick follow-up. In cases where we, the state, provide Medicaid services that are maybe beyond what are funded by the federal government, do we also track those costs? Do we know what those costs are?
Absolutely. And in we are working on a presentation for later this month that will give an overview of what Maryland Medicaid currently covers and why. And part of that will be breaking apart. This is what we are required to cover under federal law, and this is what Maryland chooses to cover above and beyond that.
Great, that's what I was asking for. Great.
Yeah, so we'll be able to get that information to you.
And with all this information, if you get it to the committee and staff, we can disseminate it to the members.
Absolutely.
That's going to be great. Other questions? Thank you so much. Very informative. We
Thank you
appreciate
very much.
You have a great day. We have Maryland Department of Human Services. I think Chief Yee is with us and Assistant Secretary Handerhan. Welcome.
All right, good afternoon, Mr. Chairman, Madam Vice Chair, members of the committee. My name is Webster Yee. I have the privilege of serving as the Chief of Staff for the Maryland Department of Human Services. With me is my colleague, Larry Handerhan, the Assistant Secretary for Programs. We brought Mr. Handerhan over after distinguished service with the U.S. Department of Health and Human Services, where he served as, I think, the Deputy Assistant Secretary for Management at the Administration for Children and Families, as well as at the D.C. Department of Human Services. And we gave him one very fun homework assignment the moment he started, which was help us implement H.R. 1. And so he's here to talk about H.R. 1. I'm here to talk about SNAP payment error rate. Together, we'll try to answer all of your questions. And then I believe we have something like 16 or 17 budget meetings between us and Health with Chair Shetty and the Health and Social Services Subcommittee. So I'm sure if you have any questions, we'll be happy to discuss it over and over and over again. There'll be plenty of time for that. First up, with a lot of thanks to our colleagues from the Department of Legislative Services, Ms. Zimmerman, Mr. Gutlerbert. We put up a lot of data. I'm going to refresh a couple of very key items. SNAP serves 680,000 Marylanders. That number obviously will change a little bit depending on the month. The two parts that I really want to highlight here is over a third of that number are children. So these are kids who cannot work. They're kids. The second part that I really want to highlight is we pay out about $1.6 billion in total SNAP benefits. Those are 100% federally funded prior to H.R. 1. That cost differential changes now, as our DOS colleagues pointed out earlier. One key number, though, is the $180. That's the average monthly SNAP benefit per person in the state of Maryland. That corresponds more or less to what it is nationally. $180 is not that much money to help put food on the kitchen table in this time of increased grocery prices. This is a document that you all will see. We've passed out hard copy packets, and it's broken out by region. As you can see, there are large impacts on Eastern Shore and in Western Maryland. There's also, of course, impacts in the Central Maryland regions. And again, there's a lot of kids. Also, as part of this, the federal government shutdown, the longest shutdown in history so far, deeply impacted the administration of SNAP in November of this year. The federal government used previously issued federal fiscal year 25 funds to fund October SNAP benefits, but they announced literally a day or two or so before November 1st, hey, we're done with November benefits. And so they stopped funding for a period of about 17 days, SNAP benefits across the country. Maryland stepped in. The governor was very clear. Our first and foremost job is to ensure that people were able to put food on their kitchen tables. And the governor took two decisive actions through executive order. The first was a $10 million emergency grant to support Maryland's food banks and community food pantries. We got that money out in 2 weeks. And we worked in an extraordinary partnership with both the Capital Area Food Bank for Montgomery and Prince George's counties and the Maryland Food Bank and over 100 food partners across the state to ensure that every jurisdiction was able to put out some food in emergency food assistance. The second item was we used state funds to make SNAP customers whole following a federal judge's order that the federal government provide contingency funding for the program. We ended up using about $2.4 million of state taxpayer funds. Under the most recent federal budget law, states may apply to get those funds reimbursed. We're currently going through that process right now and trying to find out from the federal government how we can go through that. The second part is by November 18th, we had restored SNAP benefits with an extraordinary amount of work with our MD Maryland Benefits partners. They were working through the weekends, almost 24 hours a day to get this going. And you'll hear more about it from my colleague Pat McLaughlin in a little bit. And I'll turn it over to my colleague Larry to talk about HR1.
Sure. Thank you, Webb. Really pleased to be here, and thanks for the time. So I'm going to recap some of the information that you heard from our DLS colleagues around the eligibility obstacles and restrictions and reduced benefit values that actually took effect November 1st, 2025. So unlike some of our other colleagues in the Medicaid space, the changes to HR1 for SNAP are largely in place already, at least on the customer side. So that includes the expanded work requirements that you heard about earlier, the fact that refugees and people granted asylum are no longer eligible for SNAP, and the fact that households without an elderly or disabled member no longer receive that higher payment that's tied to their utility assistance. I'm going to dive a little bit deeper into each of these areas, especially the work requirements. But again, this started on November 1st. It subjects new applicants immediately. Other participants will be impacted as they get their redetermination, which generally occurs every 6 months. So because you can receive 3 months of SNAP in a 36-month period, that's how we're tracking March as the first month that you're actually going to see people lose benefits. But I think it is really important to know that these restrictions are in place now. Back one. All right, we mentioned this number that up to 80,000 additional Marylanders will be subject to work requirements. Here are the categories that we talked about. So older Americans, so between 55 and 64. I think of the second category as basically parents of teenagers only. So these are folks who previously might have had an exemption because they had children under the age of 18, but that has been lowered to needing to have children under the age of 14 in the household. And then categorical eligibility, veterans, individuals experiencing homelessness, and former foster youth under 24. If you flip to the next slide, you can see a chart that talks about the before and after, because I think this can be really confusing, and we're going to talk about some of our comms efforts in a moment, but most people are going to have real trouble understanding if they're impacted by the HR1 changes until they present for their redeterminations. So you can see in the HR1 categories, it was a much broader swath of folks compared to post HR1. It includes both the age of the child and the age of the adult, the categorical categories that go away, but importantly, people who are disabled in a drug or alcohol rehab treatment program or who are mentally and physically unfit for employment, they're all still exempted. The definition of unfit for employment is not spelled out in the law. Next slide. In addition, we talked a little bit about this, but Heat and Eat was a program that we administered here in Maryland that allowed SNAP benefits to be slightly higher if you received energy assistance through the state. That flexibility is now gone to be categorically included in that unless you have an elderly or disabled member of your household. Importantly, as DLS mentioned, a lot of people are still going to be eligible, but they're going to have to submit documentation. This is going to be a real challenge for us. It's going to be more work for our staff, more work for our customers, and we'll talk about the technology and communication strategies we're going to leverage to make sure that as many people as possible can get that higher benefit amount.
There was discussion earlier about the SNAP payment error rate, and I just wanted to provide a couple bits of information about the SNAP payment error rate. We also provided in hard copy I think it's a 6-page document with a lot more information, so happy to discuss with members offline about this. The most important part is the SNAP payment error rate is not a measure of customer fraud. It is a federal measure of how accurately states determine eligibility and benefit amounts by checking the number of under or over payments. And so in the slide here, we've listed out what is an underpayment and what is an overpayment. This is a quality control check on a state agency's administrative processes. So it's how the Maryland Department of Human Services as a bureaucracy and how well do we function. Prior to 2023 and 2022 and through COVID, we had issues. Our state vacancy rates were sky high. We had adopted a new technology platform that didn't work that great. And we had lots of folks who weren't talking to each other or being trained consistently. Those are items that we have systematically fixed since 2023. That's how we dropped our payment error rate by half in the first 9 months in 23, and how we've delivered additional payment error reductions since then. Additionally, and right here, I should have switched to the next slide. This is the information on that. As you can see, we've had the second largest reduction in SNAP payment error rate in the country from federal fiscal years 22 to 24. The way that the United States Department of Agriculture calculates their error rates, they release it in June of the year following the end of the federal fiscal year. So the next release of information will be in June of this year for information for the federal fiscal year ending September 2025. So it's almost 9 months behind. And any of the work that we're doing now will impact next year, basically. So it's a bit of a delay. What we know now, I've provided some basic information. Again, the key factors that we've identified were staff caseloads and turnover, systems issues with our technology, and then changes in federal policy. But we're fully expecting that what happened in October and November, and then now through March with the implementation of H.R. 1, and all of these changes in federal policy, and also due to the federal COVID unwinding to have substantial impacts on our SNAP payment error rate. To give you a lot more information, this is the breakdown of SNAP payment error rate. I definitely don't do math. I also definitely don't do statistics. This is the representative breakdown of the statistics behind how the federal fiscal year 23 numbers were calculated. As you can see, there were about 1,100 cases that were sampled. The total dollar value of the errors was about just under $43,000. And as you can see, Maryland made more in the overpayment side, so we overpaid by about $33,000. The average error amount was $225, and that's based on the average monthly benefit value of $180 for context. The total underpayment value was about $140 in error. Also, again, with the $180 per month in context. So that's the breakdown. Happy to discuss the math or to connect you with the folks who do the math to discuss this further. Another key part that really was important was when we came into office, our staff vacancy rate was high. We've now reduced that to about 4% as of this year. We've been at about 4% for the past 9 months, and that's been extremely important in how we've attacked this problem. Early when I first started at the Maryland Department of Human Services, I went to a staff training. I believe it was in Baltimore County. It was a really nice crowd of folks. They were all really enthusiastic. They also had to sit through a 100-slide PowerPoint on training. I think I can safely say that for most human beings, going through 100 slides is not the way to train and be effective in calculating very complex government calculations. We've done a lot to reduce that. We've spread the training out. We've made it more human-centric. We've also, because every human being learns a little bit differently, figured out different ways so that it's not just death by PowerPoint. In addition, we've continuously hired to fill every vacancy across the state. And so we've systematically asked every local Department of Social Services, how can we support you better? How do we empower you to director so that you can provide the unique services that are necessary and needed in Allegheny County, Garrett County with Delegate Heimbaugh, or with the Eastern Shore counties, or in Montgomery County itself. Each county is very different. The second part is, and I'll go very quickly through this, Mr. McLaughlin will speak more about this, is we've used technology to say, hey, how do we do things more smartly, more efficiently, and how do we automate things so that we can do this more effectively? Some key items, when if I were to put in an application and I'm missing a utility bill statement, we can have the computer flag that and then try to connect the dots. If we know that information with BG&E or PEPCO or whatever, how do we bring that information together so that it's a lot faster and there's less duplicative, please send us some information or else we'll deny it. We're also focusing on automating select functions such as no change periodic reporting so that our employees can work smarter, not harder. In addition, we've basically picked up the phone and said, hey, we need help. And we work with the National Governors Association, with the United States Department of Agriculture. We've listened to other states, and then we've reached out to other partners such as Georgetown University and Code for America to say, hey, how do we work together to develop solutions that don't cost a lot of money or that are using philanthropy to bring in money or other federal sources to bring in money so that we can then improve our performance.
So I think you're going to see a lot of the themes from how we're addressing our payment error rate and how we are approaching implementation of HR1. First and foremost, our mission is to minimize harm and preserve lawful access to benefits as we implement this new federal law. We want to do that in a way that's human-centered, so really putting our customer first. We need to build the practical solutions on using the data that we have and the technology that we have. And we do that in partnership with our sister agencies, but also the really robust community of local organizations across the state who are going to be trusted messengers for our customers. So what are some of those strategies? Last summer, we launched the Maryland Benefits One application. I know this committee has heard about that before. That serves a really important foundation for us to do this work moving forward. We also have expanded our SNAP E&T partner network. So we previously funded 30 organizations. We're now up to 48 with an increase of 19% over fiscal year 25 funding to make sure that our customers are able to get the connections to job supports that they need, whether they are newly subject to these work requirements or just in general for the ability to the program to serve the population in Maryland. We've also built a new screening tool so we can identify exemptions for customers who qualify. This is something that we will use on our staff, but also empower our community partners to leverage to make sure that we are adequately implementing the exemptions that exist. I would just add there that we know a lot of our customers are working, they are volunteering, they are in training programs, and the documentation is one of the most challenging pieces, which I'll talk about again in a moment. We have a central web page which is linked in the slides, and that has been up for a while. That is both for customers and partners to make sure they have the most accurate information. we, similar to the payment error rate, we're looking outside the state for best practices and for additional resources. This is a very complex and challenging situation, but we are not going through it alone here in Maryland. We received actually 2 grants in the state, but one that DHS is a part of through the Public Benefits Innovation Fund to leverage AI and other tools to improve the customer experience. Specifically, that is to enable income verification, documentation sharing more easily on the customer side, among other things. We're really excited about that. My colleague in Medicaid, Deputy Secretary Briskin, mentioned the role that CRISP can play, and so we're working with the Maryland Healthcare Commission to use the diagnostic data that we already have at our disposal here in Maryland to make sure that we're automatically identifying and exempting customers where we can. This saves the work from the customer. It also saves the work for our staff because it is incredibly time-consuming to work through what we would call an ABOD case in SNAP, and we do expect that that is about twice as much effort for our staff as a case where work requirements would not be applicable. In addition, we are partnering with really anyone who is interested. So if any of you have ideas, please let us know. We're going on a bit of a roadshow with some of the more typical community-based organizations that we work with, but also trying to reach new audiences. We're doing that joint with Medicaid because this really is a sea change for how the social safety net is delivered here in Maryland. It's not a SNAP issue, it's not a Medicaid issue. When you think about the fact that customers are going to be the same and they're suffering from a lot of other cost of living challenges anyways. This last page has our resource portal. It has more information about our SNAP employment and training resource page. It also has food resources. There are a lot of lessons learned from the delay in SNAP issuance in November that we have been able to take to the HR1 conversation, including staying very close to our partners on the ground. Our core message is that we're encouraging people to continue to update their information and check their eligibility, apply for help at marylandbenefits.gov. We also have a call center that people can leverage, and we appreciate the chance to talk about this more today and get your help in sharing this information more broadly with customers. Thank you.
Presentation. Delegate Grice.
Yeah, I was just looking at, I don't have my glasses on now, this chart showing the cost of these error rates. And I thought that at first when I looked at this, I was like, this must be in the thousands, right? Because that's typically how a lot of our briefings are presented to us. I'm like, okay, 150,000 people, $33 million is what we're losing in overpayments. We're talking about $150 and 150 people and $33,000 is what we're looking at here.
That's the statistical.
Seriously? Oh my goodness, like we're spending more time and money in this hearing than $33,000 worrying about such a small amount of money, to be quite honest. And I will say that it's become again, I don't want to bring up partisan, but I will do my best to make sure that we have bigger fish to fry in Maryland than we're trying to recover $33,000 from 150 people, to be quite honest. And I know, when we have self-checkouts at Walmart, they do that for a reason. It's less expensive. Some people might steal some stuff from Walmart, but that amounts a lot less than it would be to hire dozens of cashiers, right? It's the cost of doing business. And for us to spend this much attention on overpayments of just $33,000, it seems like we're spending a lot more money trying to figure out where we're making these losses than that amount. This seems crazy. I don't know what anyone else thinks about it, but I will do my best to communicate that with as many folks as I possibly can. So thank you, Mr. James.
Thank you for that. Delegate Watson.
I just want to clarify this chart. This is on page 14. These numbers represent the sample, is that correct?
Yep.
Yes.
So these numbers aren't extrapolated out, correct?
Correct.
So if I'm doing my math right, it's somewhere between 14 and 25 million. Now let's walk through it if you don't mind, so we have a better understanding of it.
Sure.
So if you say, let's just go to the average error rate of $200, right? Let's just use that number as the average error rate. But you have 215 error cases out of 1,108 sampled cases, is that correct?
Yes.
So that's 19.4%, is that correct?
Yes.
Okay, so wouldn't you then take, and first of all, are these sampled cases households or recipients?
It's cases representing a household.
Okay, so wouldn't you then take 19.4% times 361,814, which is the households?
So Delegate, I think the key point here is this is for federal fiscal year 23 when our combined
I understand, but let's just work through the math if you don't mind.
Yes.
So isn't it 19.4% if we're doing this math times 361,814, which gives you a number, let's just do it. $70,000 or so times 200. So the error amount is really 14 to 25 million. I'm sorry, it's not 25 million, it's 14 million. It's 14 million based on households. So my question though is this, it still goes to Delegate Rice's point, because isn't our penalty 200 million?
So there's actually two sets of penalties. There's the actual payment error rate liability, which was assessed at about $17 million for federal fiscal year 23. That's currently under appeal, and so we're waiting for a court to render judgment on that. There's a second penalty, which is through HR 1, and that's the mega number that was discussed earlier with Department of Legislative Services.
Which is 200 million?
Yes.
For our current error rate?
Yep.
So my point is still what Delegate Rice's point was, which is it's a small amount of money compared to the total amount of penalty.
Yes, we agree.
Okay. Thank you.
Thank you for the clarification, and I think it does make the point. Yeah.
It may be less a deal than I think we're.
$70 billion budget.
Yes, that's right. Correct.
We want no errors, right? We want none of that, but the draconian penalty for $14 million is not in line.
Mr. Chairman, we completely agreed. And since day one, we've said everything. How do we reduce that error rate?
Yeah. Delegate Shetty.
Thank you, Mr. Chair, and thank you, delegates. So I just want to clarify too that my understanding is that this error rate method of them working on this error rate, this is how the federal government computes the error rate, right? Like they pick a statistical sampling and then assess what percentage error rate we're at. And then what HR 1 did was establish an arbitrary number where if a state was above that error rate, then for like a year that had already been done, right? Like that data, as you mentioned, Chief Yee, was that like 9 months prior had already closed, right? So they looked at data from a prior year where those numbers could not further be reduced because it's a static number in time, right? And then determined the payment error rate was 10.8% or something, and the threshold was like 10.3 or something like that. Like whatever the arbitrary number was, like that's what our penalty is being assessed on. And so, yes, these numbers that were just discussed are whatever amount they are, but the penalty is significantly higher based on a point in time that was months before, almost a year before the actual bill went into effect. Right?
Yes, that's
right. Thank you. And thank you. And then I know also that as part of the larger federal discussions, isn't it the case that there have been bipartisan requests from Republican-led states and Democrat-led states for Congress to include as part of this continuing resolution a delay on implementation of these provisions because there is no state that is ready right now to absorb this particular financial blow.
That's absolutely right. And I think the most recent letter is from last week from the National Governors Association representing all of the states.
Yeah, thank you.
It's almost like the federal government is looking for arbitrary reasons to just cut SNAP benefits, but I don't know. Go ahead, Delegate Rice.
So this sampling was done in 2023, and obviously there must have been some issues with some controls or something within the department, because Maryland was still higher than other states even at that time. But you're saying there has been improvement, which is awesome. I mean, obviously, this is what we all want to hear. So are you guys confident enough now where if they were to take a more current sampling that these numbers would fall in line, do you think, potentially?
Delegate, I think I can say that we are focusing on reducing our payment error rate as much as we can. The national average rate is about 10 to 11% every year. It fluctuates a little bit. And I would like to say, but again, the official numbers from the USDA are coming out probably sometime in June that we're a lot closer to that national average. There's a question of whether we'll be in one of the payment error rate categories under HR 1, and I don't know. Delegate, to answer your question there.
Okay. I just want to make sure this is not a partisan issue, to be quite honest. And I agree with you guys. I mean, I hate to see some sort of draconian penalty be assessed to Maryland, especially when we're given the fact that there was no fraud, there was no waste, or at least documented fraud, waste, or abuse. We're not hearing that from the federal government at all. So if the new assessments are coming out in June, are we going to see any penalties between now and then? I mean, can we wait until then to get the new numbers, and then hopefully we'll be in the clear? Is that possible, or are we sort of stuck with these numbers from 2 years ago?
We're stuck with these numbers right now, Delegate. And again, it's going to be an evolving conversation item with the Health and Social Services Subcommittee.
Okay. All right. Well, we're on the same team on this one, I hope. So thank you.
Yeah, it sounds like we are, and I appreciate that. Delegate Forbes.
Thank you, Mr. Chair, and thank you for your presentation today. I'm going to jump back to the DLS presentation that was first today, because they talked about that HR 1 authorizes a delayed implementation for states with a payment error rate that when multiplied by 1.5 is equal to or exceeds 20%. And wouldn't that, if we're reducing ours, we're not going to get the delayed implementation, but if a state isn't working to reduce theirs, they would get a delayed implementation of this. Is that true? So it's an incentive not to reduce your error rate.
And Delegate Forbes, I think that was the intent as we understand it from the compromise negotiated with Senator Murkowski of Alaska. I know that we've gotten a lot of questions from folks to say, hey, what would happen if Maryland followed that? Maryland's been very clear. We're doing everything we can to reduce our payment error rate to as close to zero as possible. One comment about that, if you're a small state with a pretty restrictive benefits package, or you're following the federal guidance exactly and you don't have many waivers, it's going to be lower. For example, South Dakota is at 3.28%. Most of our peer states, Illinois, New Jersey, Connecticut, are right around, or Virginia, are right around our amount right now.
Thank you. Thank you very much. It seems like another flaw in the bill, though.
Well, I think we can all agree. Look, the thing to bring out of this with regard to SNAP is no fraud, no waste, no abuse, as Delegate Grist articulated, and a really draconian penalty based on our state, which is making big strides in reducing our error rate. And thank you for illuminating that. We appreciate both of you. Of course. Right, have a good day. We have one, I think, last Maryland Benefits and Executive Director Laughlin. Welcome.
All right. Good afternoon, Chair Barnes, Vice Chair Kaiser, members of the committee. My name is Pat McLaughlin. I serve as Executive Director of Maryland Benefits, formerly known as MD Think, for those who are aware of the program itself. And I really appreciate the opportunity to come today and talk about what we've been doing over the course of the last year to bring a lot of these different disparate benefits together and provide a more succinct, simplified experience for Marylanders in understanding what benefits they're eligible to receive and going through the application process. I'm going to start briefly with what the challenge in front of us was. And with having so many different benefits available from a variety of different agencies, we ran into a customer experience issue. There were a lot of different places where the customer or the Marylander had to go to learn about what benefits they may be eligible for, where they had to go to apply, what agency they had to engage with. And what we wanted to do is really take a step back and look at what that overall experience is like and what do we as a state want to provide to our customers to ensure that overall experience is easier, is faster, and does not require as many trips to different agencies or organizations to get through. So with that in mind, we wanted to look at really centralizing an overall benefits experience for our customers. And we didn't want to simply think about benefits from one particular vertical, whether it be health or human services, but more broadly, benefits when it comes to a variety of agencies that all either have the same customer base or their customer bases may be somewhat tied to or connected to other agencies. There are some core principles we really wanted to start when we thought about this overall process. The overall goal is simple: make the experience as simplified as possible for them. We want to make sure that the customer can discover the benefits that they are eligible for rather than have to kind of comb through and try to figure out the eligibility requirements. We also wanted to ensure the application process itself was integrated. As I mentioned, historically, there were multiple applications that were required that included a lot of repetitive documentation. So we wanted to reduce that overall, that process. We also wanted to make sure that we can proactively engage with our customers. One of the things we often would require is for customers to come to us to ask questions, understand updates. We want to be able to be more proactive in ensuring that our customers know the status of where they are in the overall application process. And then last is to really establish or expand a universal platform that people can come to and understand what benefits they're receiving, when they're due to be renewed, additional information about changes to their benefits, things like that. Again, not having to jump through multiple hoops to get there. So as Jeremy Baker mentioned earlier on, SNAP and Medicaid have a lot of common customers. They're not the only ones. And what we really did to think about how we can bring this to the table was look at the different benefits that seem to have similarities in the questions that were asked to the requirements that went into receiving those benefits. And while Medicaid and SNAP may stand out, there are others that also have some commonalities with those requirements, and that includes temporary cash assistance, home energy programs, and WIC, women, infants, and children. So by looking at those particular groups or benefit areas, we wanted to start with those programs because we knew if we could ask the same question, instead of asking the same question multiple times, we asked that once, we can then begin to distribute that information more broadly to those various programs. And just to kind of connect this portion back to the prior slide, we really wanted to also drive into a couple of key features when we think about connecting them. Everything we're doing when it comes to eligibility has to be rules driven. So what we do is use a behind the scenes rules engine that ensures that the policies that have been implemented or are required are implemented as intended. We're not doing this off of kind of code based, but we're actually looking at the policies that are in place to ensure that the eligibility returns are as accurate as they can be. We wanted to make sure, again, that it was a one-stop or a one application for people to come to. We wanted it to be mobile first. We know that over 60% of our customers use their phones to access benefits, and we historically have not done a great job of meeting those people on their phones. We've required them to go to a laptop or to a library to be able to apply, and we wanted to make sure that we're mobile first in the way we're thinking about this. We wanted to be proactive, to be able to text and email our customers more regularly about information about their benefits, the same way that any of you would get that type of outreach in any other sector you're dealing with when it comes to programs that you're either subscribed to or working with. And the one key thing that I think we really wanted to change as part of this overall process is only ask relevant questions. As I go through some of the highlights and the outcomes of what we've seen so far, there's going to be a focus on time, that we've reduced the time to do a lot of this work. Part of that is we asked a lot of questions historically that weren't necessarily required or relevant. They were helpful down the line, but at the point of collecting information, it wasn't necessarily required. And we wanted to really focus on, from a policy perspective, what is federally mandated for us to include in order to determine eligibility. So that's where we started. And we approached this from a two-phased operation. The first thing we wanted to do is, as quickly as we possibly could, get tools in our customers' hands that allowed them to understand what they're eligible for. This was not going to necessarily be the application integrated with those tools at first. We wanted to phase this because we wanted to get something that was going to help them understand eligibility right away, and then continue to build toward that common application. So the first thing we did is we released phase one, which is an eligibility screener. Again, I'm going to walk through some of the outcomes of that initial release. And then the second phase is one application, which, as you heard mentioned before, launched this past July, and we'll be able to share quite a bit about what progress we've seen as a result of that implementation. The other thing we wanted to make sure is everyone had a simple experience in accessing these. So they're modular in nature. What that means is you can go to marylandbenefits.gov, fill out the screener, or fill out the application. It's really easy. But we can also point to it from other websites throughout the state. So we're not requiring people to know where they have to go all the time. Rather, we can have that same information available from maryland.gov or from other agency websites, just as simply as it would be from a centralized consumer portal. So to start with the eligibility screener, we really wanted to begin our focus around those 5 core areas I mentioned up front: SNAP, temporary cash assistance, women, infant, and children benefits, Medicaid, energy assistance, and we included emergency assistance as well. And those were the core programs that we began. What our key focus was trying to simplify how that information gets collected. We wanted to keep this less than 5 minutes. If we're asking people to spend more than 5 minutes to submit this information, it was too much time. The other thing we wanted to ensure is, as part of that process, no private information is being included. It's generalized questions that allows a customer to very quickly understand their overall, the overall benefits that they're likely eligible for, to receive, without necessarily having to have all of the documentation with them at that time to submit an application. And the results of this have been pretty tremendous in a relatively short time period. So I mentioned December of last year is when we launched the eligibility screener. We started with those 6 programs. I'm going to get to some stats in a second, but before we get there on the slides I'm showing right now, I just wanted to point out that over that time period, due to these programs we've included, the success of the screener itself, and the interest of other agencies, we've been able to also include Energy Savings Program from the Department of Housing and Community Development, the Child Care Scholarship from the State Department of Education, Maryland Access Point, and the Medication Assistance Programs, both of which are from the Department of Aging, all into the screener without introducing new questions. So basically, there are 13 or 14 questions that get asked, and you have information about all of these programs now in a matter of minutes in understanding whether or not you're eligible to receive those. So what have we seen over that time period? Close to 350,000 people have, close to 350,000 sessions have been started with the screener. Of that, over 240,000 have been completed. We know there's always going to be a difference between those two numbers because anyone right now, you can open the screener up and start filling that information out. But the more important number is over 240,000 people have completed those sessions. Again, it takes just over 4 minutes to complete, and 65 of those screener sessions have been accessed by the phone. So really meeting on that overall mandate. What that allowed us to do, though, is to take that information and start to build that into what the common application was going to include. So when we launched one application in July of this past year, the focus was really to transition from that information that would be gathered within the screener and begin that application process for our customers. Again, having them enter information one time, upload documents directly from their phone without necessarily having to go and scan or find another location to get their source documents included in their application process, and automate as much of that process as possible. So we honed in again on those core 5 benefits that we wanted to start with, or I'm sorry, 6, including emergency assistance of SNAP, temporary cash assistance, women, infant, and children, Medicaid, energy assistance, and emergency assistance. And the result of this has been, we're very pleased with so far. So to date, over 261,000 applications have been submitted. That's actually the number as of January 9th. The number's over 270 at this point. 35% of those are multiple benefits. So if we think about historically having to apply in multiple locations, we're now bringing that into a centralized point of entry, which gives our customers, which is important to us, time back. So they're not necessarily spending a lot of time getting through that application process. One thing I want to point out about this next item of 28 minutes. Historically, and this was data that was brought to us from a partner, Code for America, that we worked on initial piloting of some of this work. It was taking our customers roughly 70 minutes, an hour and 10 minutes, to get through an application for SNAP, for non-Magi Medicaid, and for home energy assistance. 70 minutes. Now introducing the broader portfolio of all of these applications, we brought that down on average to 28 minutes. So if we think about the amount of time saved, 40 minutes per application, 260 plus thousand applications, that's a significant amount of time that Marylanders have gotten back in this overall process. We've gotten very good feedback so far from our customers. Just about 80% have had either a very positive experience where they've indicated the application is easy or very easy, or have responded as a neutral response. We're constantly engaging with our customers because that's really who we're working with to lead how effective this tooling is going to be. And really importantly to us, we've seen a significant increase in digital applications. So over the last 6 months, we've seen a 12% increase overall in applications that have been submitted digitally. That accounts for 72% of all applications, which is when you think about the volume of applications we receive, that's a pretty significant uptick in a very short time period. So we're just getting started, but really wanting to highlight some of the short-term success we've had and where we think this is going to lead over the course of the next several months. Just to quickly highlight what that's going to look like. On the screener side, we're continuing to adopt more programs, again, without asking additional questions. We'll soon launch the Service and Benefits program for the Department of Veterans and Military Families to be integrated with that screener process. And one thing that's really going to tie into some of the challenges we faced over the years with HR1 implementations now and some of the longer term effects we've had are introducing additional components such as redeterminations and interim changes. So when we redetermine those benefits on an annual basis, that will now be part of one application. That will make this pretty seismic shift in how we're thinking about this information being populated, coming into a single place, having more consistency, and allowing us to ultimately get people the right benefits they deserve faster. And we'll continue to work with additional opportunities with more agencies. We've already have planning in the works with the Department of Labor, Department of Disabilities, and the State Department of Education for expanded benefit access through programs that they support. We're always welcome to hear any ideas that you or your constituents may be bringing to you as far as areas that can simplify the overall benefit access process. If we do this really well, it's going to ultimately have a positive impact on a lot of the work that has to be done under HR1, because this is going to be the point of entry of that information coming into these various systems that have to manage these benefits. So with that, I thank you all for your time and happy to take any questions.
And thanks for the presentation and your good work. Questions? Okay, yes, Vice Chair.
Thank you, Mr. Chairman, and thank you for this presentation. I was looking at your road ahead and the list of items. What I didn't see was with the Comptroller's Office, like with the Earned Income Tax Credit, or with the State Department of Assessment Taxation with the property tax credits. So I was curious about that and whether you're planning to link to any counties that might provide any benefits. Thank you.
Thank you very much for that question. Yes, we have been in many conversations with the Comptroller's Office and are leaning into additional conversations with the State Department of Assessment and Taxation. We are working in the short term of a lot of cross communication around the Earned Income Tax Credit for this particular for this cycle, with the goal of next year of working more closely and how we can integrate those systems directly and be much more proactive in getting that information out at point of the information being collected. One of the things I would like to call out as part of the way that this was developed is it can be, I mentioned it being modular. It allows us to also add and remove as necessary. So if we have programs that are very seasonally dependent, we can include and then pull them out of the overall process if we need to. So that allows us to adopt some of those other programs that may not necessarily be year-round. When it comes to the locals, we are certainly interested in exploring more with some of those local programs that may make a lot of sense to integrate with.
Thank you. I don't see any other questions. I do want to thank our speaker for being with us today, our chair for helping to put this together, our committee for a great hearing. And, you know, we've heard a lot today, a lot of information. There's certainly reason to leave here disheartened by federal actions that seem intent on creating draconian penalties, heartless actions, punitive, haphazard at times. But there's also reason to leave here heartened, because we've heard from many public servants who are working in this state every day, delivering benefits to Marylanders. And so that's how I'm going to choose to leave us. We're adjourned.